Frank Stenner. Thank you for coming.
Reinhard, thank you. Thank you, the organizers, for this invitation to a very lively, as I can see, tumor center event. And it's the topic and the location, I presume, that made this turnout so successful. First, I want to say, when I look at the program, that head and neck is not the same as bladder and renal. So this is actually two subjects I have to press into one, but I'll do my best to stay in time. This we are all very aware of, and the reason why I brought it is just to show you where the leverage in GU cancer is, and actually for the tumors that I'm talking about, immune manipulation is a key element, as it is in other cancers that you have already been discussing this morning. In renal cell carcinoma, there are competing pathways that are targeted, and there we will have to find a way how to integrate immunotherapy into the landscape of that treatment. This slide is also very known to you. It is the somatic mutations in cancers, and we all have been taught over and over again, the more mutations, the more neoantigens, the better response toward immuno-oncology approaches. But the story here for the GU cancers, and to show you, bladder cancer is very high in somatic mutations. Clear cell renal cell carcinoma is, together with papillary carcinoma type, more or less in the middle. And chromophobe renal cell carcinoma is on the lower end side of this scale. When you put that into another kind of way to look at it, and this is the more inflammatory perspective. So how inflamed is a tumor? And you all know there are several things like cytokines and neutrophils and whatever in the tumor that make the tumor inflamed. And there you can see bladder cancer moves away from the lead, and here the renal cell carcinoma, the clear cell type, clearly takes over. And again, the papillary stays in the middle, and the chromophobe, we have to move up into the inflamed zone to have any success with these tumors. That is the therapeutic landscape in renal cell carcinoma, and I show you this slide just to make the point that immunotherapy was very early on an idea, and it worked in some patients, but it was a very crude approach. And to my mind, the PD-1 and PD-L1 axis manipulations that we do today are still crude. They are better than we were in the past, but we are still fiddling with something that we haven't completely understood. And I think that when we are refining this approach and manipulating on the cellular level, e.g. CARs, that is not the subject of today, I know, but that is probably the future. So what I put in colors here then is the white, the TKIs, and as you can see, immunotherapy in renal cell carcinoma has not abolished the TKIs. There are new TKIs that have preceded the immunotherapy here, and green the nivolumab. But of course, we all think that other immune checkpoint inhibitors and other agents will come to manipulate in that area as well. So what is the therapeutic algorithm today? First line, we use VEGF and mTOR inhibitor. That is still the same as it was. But second line, in the past, again, another TKI or mTOR inhibitor, that will change. And in third line, we didn't know in the past, and probably we don't know yet. So we all know TKIs work well, and for some patients they are exceptionally good and tolerated well, and they stay long on those drugs, but eventually they fail, and there are a lot of mechanisms that could be addressed. But as of today, a patient that fails a TKI, usually we would think in terms of a checkpoint inhibitor, except some probably very great responses that would demand staying on the same principle. Where are we in the whole landscape of PD-1, PD-L1 targeting with the GU cancers? As you can see, the renal cell carcinoma is in the park of OS benefit, so near or in many countries already on the brink of approval. Bladder cancer has a good overall response. I will show you that later, and will be approved soon as well. Looking at renal cell carcinoma, yes, the target is there. This is a PD-1 expression in renal cell carcinoma, and we have infiltrating cells if the tumor is positive, but there are negative tumors, as you can see here, and they look just like normal renal tissue. The PD-L1 expression, as you know, is either on immune cells or tumor cells, and if you look at the ratios in lung cancer, we have them on both parties, or a quarter of cases, and followed by renal cell carcinoma. Melanoma, of course, is higher in immune cells, but lower on tumor cells, and bladder comes in next with a quarter and 10%. And this was the study that led to the approval of the first checkpoint inhibitor in renal cell carcinoma. You're all aware of this, of the data. And the interesting thing was that they had a dose-finding study before that. And as you can see here, they chose the yellow dose, or a bit above the yellow dose to be completely correct, 3 milligrams per kilogram. But they could have chosen the other 2 doses as well. There is no dose correlation in nivolumab in renal cell cancer. A bit disappointing for all of us is that steep drop in the progression-free survival, meaning that a lot of patients will not benefit from this therapy and they will fail soon after initiation. But if they respond, then they probably respond for longer. The overall survival benefit, despite this disappointing progression-free survival, was clear, significant, and there's no doubt that in second line, nivolumab is much better than everolimus. If you go into the subgroups, and I think this is important because it tells us something about biology and how to make best use of this drug, we can see that in patients that are favorable regarding their outcome from what we knew in the past, they are doing well regardless of this drug or using the competitive drug. But patients who were frail and probably not so well off to start with, they benefit most likely the most from this kind of therapy. And another thing that is of importance is the elderly patients, and there might be the signal that immune therapy with one agent may just not be enough for an old person, because the immune system or the activation of the immune system may need more than just one checkpoint inhibitor. Regarding these numbers here, you can see on the curve there is a broad split for the patients with poor prognosis, so let's call them the frail patients. Interestingly, we saw in this phase 3 study no correlation between PD-L1 expression and response. We saw what we already knew, that if you have PD-L1 on your tumor cells, this is not a good thing. Whatever you do, your survival will be less than if you lack these PD-L1 cells. But the explanation why PD-L1 doesn't play a role in a PD-1 blockage is still to be found. This curve obviously doesn't belong in the RCC arena. This is from melanoma, and we see these nice tails. We had a hint of that in ipilimumab, but of course this is much more striking, and this is what I would call the benchmark in immuno-oncology. What about the other side, squamous cell carcinoma of the lung? Yeah, there we see plateaus as well, but they are not as impressive as in melanoma, and that is why I showed you these further 2 slides. Here we are most likely phase 1 patients, highly selected. There is a bias in that. make you aware of that, but in the phase 2 it looks quite similar, that there are patients who have a long-term benefit from this kind of therapies. What about the risk groups? Are there any differences? Of course there are. The better ones do better, that is for sure, but this tells us even if you haven't got the best starting abilities or features and you're in a poor prognosis group, you are less likely to have a long-term benefit, but you may have one. And the same is for persons with low performance status. They do worse than the other ones, but they can have long-term benefit from these drugs. And lastly, when you respond to this kind of therapy and you have a good response, your survival outcome is better. But even those patients who only had stable disease here or progressive disease, so we must say they were progressive, but they probably had secondary interventions or were treated beyond progression, even there is a kind of plateau. So in renal cell carcinoma, we assume that the future is not a single agent, but combination. I mean, that is not very hard to guess, but the problem is what is the combination partner? And VEGF inhibition by bevacizumab is one possibility, or a combination with TKI. We'll have to see. Our first information and data that we have is that not all TKIs are compatible with PD-1 blockage. That might be too toxic in certain combinations. A summary for renal cell carcinoma: TKIs are still good to begin with. Checkpoint inhibition is more than promising, actually. The dose correlation is a bit worrisome, but maybe we should, as academia, try to investigate more into this field, maybe worthwhile. The PD-L1 correlation that is missing still needs explanation, and I'm very eager and keen to see what will be the final explanation for this, and combination therapies should be key for further success. Here I switch to bladder cancer. In bladder cancer, checkpoint approaches have yielded similar results regarding the agents that were used. This is the Roche antibody atezolizumab and the pembrolizumab you're all aware of. Here, this is a comparison what we had and what we can expect in the future. This is a drug that was approved in Europe, but not in Switzerland or the US, vinflunine. And as you can see, there was a survival benefit, and that was significant, but the clinical meaningfulness of this agent is rather doubtful. On the other hand side, you can see checkpoint inhibition in bladder cancer is a principle that works. So the best data to date we have is from this study. It was a large phase 2 actually study, and it had 2 cohorts. The cohorts are quite interesting because one of the cohort is more or less a first-line cohort in frail patients. Patients who could not have standard therapy with cisplatinum and combination partner were eligible for this cohort, and patients who had prior platinum treatment were eligible for the second cohort. The first data we received at the ASCO GU was that of the patients pre-treated with platinum, and as you can see here, we had overall responses that were stratified by the PD-L1 status, no staining, and an arbitrary score of 1 and 2 and 3. And you can see that the overall response correlated in this patient cohort with the expression of PD-L1. However, if you now look at the new data, and these are the patients who had not seen platinum or any chemotherapy, you can see that regardless of the PD-L1 staining, the overall response is more or less the same. And the overall response is quite good. Now, if we think in terms of chemotherapy produces genomic damage, more neoantigens, I guess in bladder cancer this isn't all true, and we have to rethink about this concept. The overall survival for this treatment naive patients is, as you can see here, with 60% survival at 1 year, quite exceptional, and the FDA, having seen these data, has granted fast track for this drug. So this will be the phase 3, comparing the best practitioner's care against atezolizumab, and there is no crossover. The chance that this study is positive should be quite high. So when we look at the bladder cancer environment, we can see there are hot and cold cancers. So what I said with these 0 and 1 and 2 and 3. So in the cancers, we'll find the PD-L1, we find the PD-1 positive and the CD8 positive cells in hot cancer. And the opposite would be a cold cancer. And these two things, as nice as they are, what we saw now are probably not predictive for at least therapy-naive patients. And of course, still, we would like to come from the cold environment by an intervention. And when you look at the program, there is a lot of interesting talks following mine addressing this issue. How can we intervene and how do we get a tumor from here to there? And by this, provoke a CD8, here more or less dormant, into a CD8 full response. This is the cartoon showing the various ideas that are out there, and radiotherapy was already discussed and will be elucidated more later. With the TKIs and other small inhibitors, I'm not so sure if that will work, but of course this is gut feeling, this has to be shown in trials. With the chemotherapy for renal cell carcinoma, this is not an option. In lung cancer, it looks a bit like that, so we could discuss that later. In bladder cancer, as I have shown you, most likely chemotherapy as we do it now. It may be that we have to use other chemotherapies than cisplatinum and gemcitabine. But, for example, we know that this is not a typical Treg depleting chemotherapy and that fludarabine may be something helpful. But for now, the chemotherapy concept in bladder cancer is not so convincing. And if I was a patient, I would rather wish to receive immune therapy earlier than later. So this is maybe a drug that is interesting for this kind of scenario. It's an antibody against one of the immune modulatory antigens, OX40. And it's very well tolerated, and this study was presented at this year's ASCO. It starts T-cell priming and generates T-cell memory, so not only initiating but sustaining the T-cell response. And the PD-L1 induction is probably the most interesting feature of this agent. And as you can see here, this is a patient with a clear cell renal cell carcinoma. I have shown you before, there are cold renal cell carcinomas, and probably this is a patient with a cold renal cell carcinoma. But receiving this drug, you can see there is some kind of PD-L1 upregulation. And then the further you go with this substance, you have more response. And here at this point, and that was the program of that study, atezolizumab was added, and you see a full PD-1, PD-L1 interaction at the site of the tumor, and there is some response. Of course, this is one patient, this is early times, but a very interesting concept on more cellular, molecular level to induce this kind of answers. So, what we know today, let's summarize it. Checkpoint inhibitors, they work, but again, in GU cancers, only in a fraction of patients, but the fraction is higher than in other cancers, but it's not first in class, I would say. The current predictors for the outcome of our therapies are sadly insufficient, and we usually have to do, if you want it like this, the experiment before we know if a patient has benefit or not, and this is a sad thing, and we should work on that. Side effects, and there is a talk about that later on. that will be very interesting, are manageable, but they are a challenge. And even though we think this is a really soft kind of therapy, we all that we treat these patients know how disruption of therapy may look like and how critical things may become during the course of therapy. Long-term responses are there, but they are not predictable. That would be, of course, the golden grail. On the bottom of the slide, I listed what I think is important, where we should go. We have to find predictive markers, okay, that is repeated over and over again, but it will be important economically and for the individual patient. The dose optimization, and I think this will not be done by our industrial partners. This has to come from academia, and we should work on that. The same with duration of therapy. How long shall we treat a patient, and when can we stop? A question that doctors and patients ask them every day, I guess, now in these times. And the timing, where shall we put the therapy? And is there a universal timing, chemotherapy first for all, no chemotherapy first line? That is something that will be with us in the next years. And finally, let's explore the other therapies critically. Is there a place for vaccination? We have heard about the TVAC trial. This is a very interesting concept, but it has to be tested in trials. We shouldn't do that outside of trials. What's the place of surgery, radiotherapy in this new landscape? So I finish with this. I find that urogenital tumors are getting more complex than ever before, and this is a patient with a CT scan, and beforehand he had that picture, and when he brought it back I was really wondering what the problem was, but yeah, you may see for yourself. Okay, that was GU cancers, and if there are any questions I'm happy to answer them.